We only, we only ever use Zoom for CNI, so that's the only ever
Yeah.
time I ever touch it.
Hey guys,
Okay.
welcome, welcome. Hope y'all had a nice long weekend and a whole day of getting back into it before you had to really have to work. Right, Steve?
Yes.
Gotta ease back in. Okay. It is 11:46. So Julie is co-facilitating today because Kim got called into a meeting, which happens. So if you want to go ahead and make sure that your name is changed to Spoke or Hub, we will get rolling here in just 1 second. Looks like we've got a few that are not here. Got gold stars for those of you that showed up at 11:45.
Mm-hmm.
Okay, just one more second. 1, 2, 3, 6. Okay. All right, guys, I am going to vote that we just get rolling and people will come in and I'll manage the waiting room. But welcome everybody. Let's start as we always do with our introductions of our spokes team. Gloria, you are first on my screen this morning.
Good morning. My name is Gloria Lima, and I am the bilingual resource and referral specialist at the UNC Autism Program, and I am based in Chapel Hill.
Awesome. Dan.
Hey, I am Dan Derman, and I am also a resource and referral specialist with the Teach Autism program at the Chapel Hill Clinic.
Corinne.
Good morning. My name is Karen Kusa. I'm a supports manager, sorry, at the Arc of North Carolina in Raleigh.
Shelly. You're muted, Shelly.
I'm Shelley Bailey, and I'm a BS qualified professional with Bailey's Respite Care in Wilson, and we're an agency provider under Trillium for the 1915 I and Innovations Waiver Services.
Amy E, I'm gonna skip you because unless you just want to go. I'll wait till you're wherever you're supposed to go. Dania.
Hi, good morning. I'm Dania Trout. I'm the Development and Community Outreach Director at the Family Support Network of Central Carolina. And we are located in Greensboro, but we reach a 5-county area. We have offices in Greensboro, downtown, and in the hospital in the NICU.
Tam.
Hi, I'm Tam Munar. I'm an autism resource specialist with the Autism Society of North Carolina, and I'm based out of Fayetteville.
Marion. Marion, you are also muted. That's okay.
Sorry. My name is Marian Jenna, and I am a brand new family partner with VIA.
Awesome. Amy Eyeshide, I see you. You're good.
Thank you. Yeah, I got kicked out of a room. So I thought I could take the meeting. And yeah, my name is Amy Eyeshide. I'm a family navigator and program coordinator for the Whole Brain Health Program at the UNC Carolina Institute for Developmental Disabilities.
Awesome. Amy W.
I'm Amy Westcott. I'm a social worker at Novant Nunley Pediatric Multi-Specialty Care in Wilmington. We serve all types of specialties with kids.
Kay.
Good afternoon. Well, not quite afternoon. Good afternoon. Well, good morning, guys. It's my name is Kay Freeman, and I am head of community health with Trillium. Let's see, I work in the southeastern region, on the rural coast of North Carolina, It's located here in Lumberton, which is Robeson County.
Thank you. Quiana?
Hey,
Oh,
my name is Kiana Miller, and I am a family partner with Via Health. And I serve Vance, Granville, and Franklin counties, and that's fine. Thank
no,
you.
I'll get it right. No, you deserve to have you called by the
Yeah.
right name.
Oh
But
yeah,
I'll get
yeah.
it. I'll get
I definitely understand. You
it.
did better than a lot.
Thank you. Thank you. Good to see you. All right, let's do our hub team. Morgan.
Hey everybody, Morgan Parlier. I'm with UNC Carolina Institute for Developmental Disabilities. We serve across the state, but located out of Chapel Hill, Carrboro.
Yeah. Steve.
Hey everyone, my name is Steve Strom. I am the board member on the North Carolina Fragile X Foundation, and in my daytime job, I am the Money Follows Person project director.
Fantastic. Christy wasn't able to be here today. Julie, that's you.
Yeah, I'm Julie Davis, and I'm a family partner at Via Health and do all of our intake screening and assignment for our team and our referrals and lots of other little hats to go along with that one.
Thanks for co-facilitating today. Good morning, y'all. I'm Melinda Plew. I am Director of Advocacy and Chapter Development for the ARC of North Carolina. We, of course, serve statewide, and like many of you, I am also a family member of somebody with IDD, and I am co-facilitating with Julie today. So the first thing that we do in an echo session is I do my shtick. So let me read that to you real fast. Welcome to today's echo session. Our purpose in these sessions is in telementoring those of you who are providing family support in North Carolina for the IDD community. A reminder that ECHO stands for Extension of Community Health Outcomes, and it's a lifelong learning and guided practice model that has the goal of spreading knowledge, expanding capacity, and accelerating collective wisdom. As such, we are a learning community representing a group diverse in experience and knowledge. Everyone has input that is important, and we are here to all learn from one another. Do not feel intimidated by your lack of knowledge or experience. Please put yourself on mute right now and unmute yourself if you wish to speak during a session. Use that hand raising feature because of the people that may not have access to video. We do want your cameras on so that we can see your face, unless you are here to observe, in which case we have those people with their cameras off. Please, we're only using the chat if we're sharing a resource with the entire group. Remember that we are capturing all these resources and recommendations and your clarifying questions and sending those all out to you with a copy of the recording. So don't feel like you need to take notes. We recognize that it's your lunch hour, so please eat, drink, stand up and stretch as necessary. And please, when we're asking questions, make questions simple. If that is something that speaks to you with the newness of your job, ask your dumb questions, because there are none of those here, I promise. We want people to feel welcome here. So with that, I am going to introduce my colleague at the ARC of North Carolina, Francisco Chang, and he is one of our senior care managers. Tailored care management is what we are talking about today. And I am not going to give you a history lesson, but as somebody whose family member receives TCM from a community organization, I can tell you that that person that does it is a lifeline for my family member and for me. And so when it is done well, it is really, really critical. And Francisco is a champion for this service. And we like to have him in these sessions because he cares about it and the members so much. So I am going to turn it over to him, and I'm going to be quiet because he can talk more than I can. Francisco.
Thank you so much, Melinda, and welcome everybody. My name is Francisco Chang. I'm a senior care manager at the Raleigh office. I'm actually Corinne's neighbor in the Raleigh office. And so the Triangle region, we serve Wake County, the surrounding counties. There's two offices for our tailored care management program in this region. One is in Southern Pines and the other one is in Raleigh. So for this overview of what can tailored care management do for me, I'm gonna keep it ground level, easy to understand. Please ask lots of questions. My format today, I wanted to illustrate what Taylor Care Management is doing in the community by sharing a couple of stories. The care management program has been in place since December 2022. And since then, we've supported over 500 families at this point. I think we're out of assigned 900 to get started. So we're around the 500 mark right now. So I'll share some of the stories to illustrate, what Taylor Care Management can do.
Just in the Raleigh office, right, Francisco? Your 500
Just in the triangle region between the Southern Pines office and the Raleigh office, we're assigned about 900 individual, and we're actively engaging and supporting around 500 of those individuals. So my care management journey actually started in New York. And as a matter of fact, let me make sure I'm sharing my screen. Yeah. Let's see here. So share screen. There we go. How's that? Can you guys see that? Cool. So let me tell you a little bit about myself. I started my care management journey in New York in 2012. Back in 2016, there was this big initiative nationally because of the Affordable Care Act, Health Homes, this initiative of care management started to hit our population. The main goal with all of this care management was to reduce the cost of Medicaid while increasing the quality of life for the individuals that we support. So in a very basic way, care management, when we're doing services for individuals, we want to make sure individuals are included in their community, that individuals are as independent as they can be with supports. They make sure that they're able to develop relationships, develop goals, maybe seek some employment. We're really trying to maximize the choices that individuals with developmental disabilities are experiencing in the community. We're really trying to level the playing field. So if I was doing a crash course for a care manager, what does my plan need to include for care management? In what kind of way am I going to help the individual be included in the community? In what kind of way am I going to help them be as healthy and productive with their time as possible? What kind of choices am I giving them? One thing that we often see is isolation. Children, they might go through IEPs in school, they might get some special education, but then once the school ends and the IEP drop off happens, at age 22, we find individuals might not be doing much with their time at home. And so we provide them the care management to make sure that, they're taking care of their health, their activities, and, they're really moving forward with their lives. Okay. We also meet individuals where they're at. We literally meet them where they're at. When we're assigned individuals, we work with the tailor plans. Some examples of tailor plans are Alliance, Via. Right now, I know there's also partners in the West. So these are basically health plans that we contract with to provide this whole person care to the individuals that we support. So, when we're training care managers, they do about 80 hours of training. The amount of training they go through because of the requirements for Medicaid is extensive. But I often tell them, if you don't remember anything, we got to call everybody every month, and we got to make sure we visit them every 90 days just so that we can see them, speak with them, see what they're experiencing in their living environments, where they work, where they play. We have personal outcome measures at the ARC, and so we kind of like to look at those environments. And the best way to see individuals in their environments is by being in the same room, the same breathing the same air. When you call somebody and they say, "Oh yeah, I'm good, everything is going fine." It can be very different when you go see them in person, and then you get to see them in their trailer, in their apartments, in their homes. You can highlight things, changes, positive changes that, can impact their lives. So that is care management in a nutshell. Is whole person care that helps individuals with IDD be as included as possible and being supported to be as independent as possible, as well. There's a big medical component as well to care management. When we talk about Medicaid and the cost to Medicaid, hospitalizations are a big cost to Medicaid. We see that sometimes individuals might be going to the hospital for stomach aches, for chronic headaches. So when we say we meet individuals where they're at, we literally tried to figure out, like, okay, we're calling you because you went to the hospital last night. It seems like it was a simple headache. Can we get to know you better so that we can, prevent future hospitalizations and maybe get to the bottom of why that headache is, why you have this chronic headache. So by increasing the quality of the care, we're providing compassionate care, you know, understanding, the circumstances under which, they couldn't go to primary care. They might have not gotten an opportunity to go to urgent care, and that's why they're visiting the hospital. We're developing these relationships so that individuals and families can trust us, so that we can then provide solutions that don't include a hospital visit. We know a hospital visit, including an ambulance ride, could be $3,000 to $5,000. It could have been a simple preventative care visit with maybe some support over the phone, to get to urgent care, or maybe get to a on-call doctor that can prescribe something and then see them the following day, given that it's not a life or death situation. So providing that advocacy, meeting people where they are, that's what we've been doing since 2022, when we started with this model. All right. So to illustrate some of these factors, with the medical care, community care, linkage and referral. With regards to medical care, these are just some examples of what we can do to help individuals manage their own medical care. In the past year, there was an individual we supported in the Raleigh office throughout the years, through different programs. Once we offered tailored care management, she decided to jump on. And so we already had history with this family. We knew the kind of supports they've been using. But last year, we came across this situation in which the individual was not a baseline at all. The individual started engaging in disrupted behavior. They were headbanging. They were being more aggressive than usual. And the mom was desperate, because often we find that parents still need to work while meeting the needs of their children. So they really lean on their QPs, their providers, to really make it work so that they can get the respite and the care they need while they go to work. And this situation started to go south, because as the behaviors increase, moms started to lose work, and that can be stressful too. And one thing we have to remember is that when people are under stress, they might not be thinking clearly. They might not be making the healthiest decisions for themselves or for their children. And so care management was able to provide her with guidance and a little bit of, a closer look, not only providing the empathy to the family, to the mom who was very stressed. She started being a little sharp with providers, giving her, missing work and the economic situation. The chief complaint is, no one can help me with my daughter, and I'm starting to lose work. We started talking with the primary care doctor. We started talking with the neurologist. We started looking, with the mom. What are the medications? What are some of the symptoms that she's experiencing? After the full medical review, we were able to find out that mom was not doing the medications correctly. And what the individual was experiencing were headaches because the individual was nonverbal and the medical side of things wasn't fully explored. They didn't realize that all of these behaviors were because of a medication. Because this family was provided with tailored care management, because we met them where we are, because we were emotionally patient with them, we were able to devise the solution, which was a new medication. Yes, there were a couple of inpatient hospitalization days just so we can figure out, is this going to be the correct medication? And on top of everything, the family did not speak English, which was another barrier to providing accurate medical care. That was one of the barriers preventing mom from understanding there's 7 medications I'm managing for this child. This medication is for seizures, this medication is for headaches, this medication is for all of the side effects the seizure medication is causing. So without that care management advocacy, without that closer look, without that empathy to get into the nuts and bolts of the medications, this child would have kept on going to the hospital. She might have stopped living at home. Mom could have potentially lost her job. We continue to serve this family. The situation has stabilized. We continue to remind about neurological appointments. We continue to assist with Medicaid transportation. Transportation was another big factor why medications were not picked up or appointments were not kept up. So this is just one story of how with the medical care, it really comes down to empathetic care, helping parents feel listened, helping families understand the jargony medical aspect and how that interplays with providers, day programs. QPs also need to know this information. And without the help of a care manager that can speak both English and Spanish and guide the family through that medical care, the QPs wouldn't have accurate information to say, okay, now we got to update the plan with the new medication. We got to update the behavior plan with the new medication. That care manager really is a kingpin to keep the entire team together and address some of these frequent flyers at the hospital or hospitalizations. So that's just how we can assist with medical care. We is probably going to be super helpful. You guys also know the core functions. So some of the core functions of care management include and are not limited to comprehensive care management, coordination of care. That coordination, it can be from appointments to transportation to coordinating pickup of medications with the family, providing them resources to be able to get the transportation. Health promotion is one of the other 6 core functions. The comprehensive transitional care, when individuals are moving from a higher level of care to a lower level of care, we call that transitional care. If somebody's going from a group home maybe to living in the community or vice versa, we provide that communication and coordination. And we also are kind of a Swiss Army knife of service providers out there. Many times there might be situations and we don't know exactly how to address those situations. We can lean on our care managers to be able to see their previous experiences. And this might not be the first rodeo for a care manager. The care manager might have run into this situation with another family and they can share their experience of how they address that situation. I want to say like care management is big on human capital. When we're trying to develop human capital for the individuals that we support, we might need to use some of the human capital, some of the network that the care manager might have developed for themselves. These IDD communities, while we support large large service areas, the IDD community is so little. We know the QPs, we know the agencies, we know the hospitals, we know the health plans. Many times families just need to get talking with the right person. They start talking with their care manager, and then the care manager, links them to the right QP, the right agency, and the right doctor, and there you go. You're using that human capital to, start moving at 100 miles an hour. Often families land in North Carolina, they don't know anyone, and they don't even know where to start. Care management addresses that situation too with transitional care. When it comes to basic needs, when we're providing that whole person care, we've illustrated that first push, the medical push. Tailored care management was implemented in North Carolina to reduce that medical need, the cost of addressing the health of North Carolinians. We also need to look at social determinants of health. When we talk about health, mental health is a big portion of that. How can we be in the best possible health if we have food insecurity, if we don't know if we're going to have a roof over our heads? All of those factors intersection with health. So if we want to make a substantial impact on North Carolinians' health, we need to look at their living environments and the resources they have in those living environments. Health is more than doctor visits. That's why I wanted to illustrate this with a story from a family that we support in Benson. Again, the relationships that we have with some of these families go way beyond care management. The previous story, this family was already affiliated with the ARC. Same with this family, we were able to sell them on care management. Like, hey, you've been with us for a number of years. Would you like to try the care management? They signed right on. This is also a Hispanic family. They were refugees from El Salvador. And in the current political environment, in the current economic situation, some of these families have some very real challenges. When they reached out to us in crises, the family was totally isolated. It was just a mom and her son. It was an elderly lady. She did eventually ended up passing away. And what I want to highlight is that without the relationship that we had with that family, with their community in their street, she passed away very unexpectedly. And because we had the relationship with their family friends and their neighbors, we were able to find out what happened. And as a matter of fact, I went on a home visit to do a wellness check, and it was the individual who answered the door. And this individual was not supposed to be opening the door for strangers. And when he allowed me in and I saw the state in which his mom was, we had to call 911. 911 came and picked her up. And so we were able to come together as a community for this individual. We were able to provide some resources for some of the friends, their neighbors, to come stay with this individual. Because I don't know if you know, but finding a residential service overnight, it's near close to impossible. And I want to highlight the relational part of care management. With First and Family Supports, we were able to get food, we were able to get some respite funds, we were able to help the neighbors stay with the individual at his house while we figured out with the hospital, with DSS, with APS, what's the next place we're gonna be helping this individual move to. Because we had the trust from the family, because we knew the circle of support, because we did a plan. Those individual service plans include, who are the important people in my life, what does my daily schedule look like, what are some aspects of my medical care, what are some of my personal goals. We were able to get this individual's life back on track in a group home with the supports and staying connected to the individuals that were helping this family, because Very unfortunate that the mom ended up passing away. But if it wasn't for the relationship they had with care management, we see the individuals actually get stuck at the hospital, and it could be months that they're stuck at the hospital, and their mental health is going to decline. If their mental health declines, their health declines as well, and it's going to be way harder finding a fully integrated group home for somebody that is not, well regulated and has been sitting in the hospital psychiatric room for 1 month. Again, we provide assistance with basic needs, but it is the relationship that we develop during those, provision of basic needs that creates kind of like a mini family, and in helping these systems work with Medicaid, work with the hospital, work with DSS, it's so relational. It's really knowing aspects of that person's care to make sure that their health doesn't get worse. We can only do that by developing a relationship with those families. That's why I always, when I'm training care managers, I tell them, if you only remember two things, is call everybody every month and visit them at least every 90 days. The amount of information about that person's life we can gather from just breathing their same air in their living environment, we're going to walk away with that, with many suggestions and potential goals that family can work on with supports to better their own life, because that's the other factor. We provide a lot of resources, but we teach you how to fish. Is we don't want to bail you out or do things for you. This is most successful when we're teaching families how to fish for themselves while providing them the advocacy. All right, and so let me move on to the next story, and then we can, talk about questions in a little bit. Care managers can also provide support for school, work, and the future. For this one, I wanted to share a story about somebody who was doing a little bit of transitional care in the Raleigh office. This is kind of a success story because, through Community Guide, which is another service that we were providing at the Arc of North Carolina. I don't know which offices are still providing Community Navigator. That service does still exist in a kind of different capacity, but we had developed a relationship with a family through school, and then when care management landed, this individual was graduating and going into UNC. UNC has a program, is kind of like a college life prep program in which individuals can get college credits and then use it for a degree later on. And so when we developed the service plan for care management for this individual, one aspect was that they want to go to college. They still need supports to be able to participate, interact safely, socially, but still, get work done to get some of that college credit. They need a community specialist, a community networking specialist. So we talk with the higher ups, the directors of UNC. We explain to them what innovations is, what services we're providing to some of their students. We developed a relationship with them, and long story short, we were able to implement innovations waiver services inside of the college setting so that this person, can attend their college classes. They can get that one-to-one support through their waiver, the innovations waiver, can pay for many of the supports that are otherwise not paid for by Medicaid. So by developing that relationship with school and, keeping track of that person's transition out of school, supporting them through the IEP process, supporting, some individuals, not everybody has an IEP. They might have a 504 plan, but we go to school meetings, we meet with the teachers, we meet with principals. Sometimes we walk in there and the situation might be contentious between the family and the school staff or college staff, we're able to smooth out some of those relationships, provide solutions, tangible solutions, because everybody wins in that situation. The QP gets to work on the goals and provide this service in a fully integrated setting. The student gets to get help. They're provided the help they need to participate in the class, and they're safely interacting with others in the community. Safety is a big reason of why we develop those plans. We know individuals that we support are bright, they're intelligent, they're talented. Sometimes we need that layer of safety for them to be able to do it independently in the community. So, many of the individuals that we support are extremely capable, and the care management plan is just leveling the playing field for them by maybe providing a one-to-one staff, or paying for equipment or paying for classes, because it can with I want to be transparent about like $500 to $1,000 per year that the waiver can help out with class and conference, but that's a resource in there. So advocacy, the Arc of North Carolina, we provide many services, but if we were only allowed to provide one service and one service only, that will be the advocacy service. Your care manager gets to know you and the individuals that support you so that we can provide this advocacy. I want to share this story in regards to an individual also from the Raleigh office. And since last summer, they've been going through kind of a crisis situation, because this individual, their guardian, unfortunately was diagnosed with a terminal form of cancer. So since last year, they've been trying to figure out what's next for the individual that we're supporting. We know they're not going to be able to live in the same setting because of this new diagnosis. Their parent has been provided, and this person also recently went through transitional care, going from out of high school into the adult world, working, starting with VR supports. So we were able to, get support from family members, get support from service providers. We had a number of meetings to figure out what kind of advocacy do we need to provide to this individual now that, their parent, basically the person who raised them, is no longer going to be with us. How can we continue to provide that support so that this individual, it's yes, it's going to be a huge slowdown, but how can we help this individual stand on their own feet and continue with their goals? So long story short, this individual last month just became their own guardian. They were able to reinstate their rights, and present with the judge, or with the county clerk. We were able to show, and this wasn't the individual speaking directly with the clerk advocating for themselves. We in the past year, we've met goals about money management. We met goals about finding the job. We really pep talk this individual about like, what do you want for your life? And, if you want to live on your own, if you want to be able to maintain your own job, you need to show us that you're able to provide your own reminders. We're going to support you, with meeting you monthly, talking about some of your budget goals, talking about some of your employment goals, meeting with your vocational counselor, so that you can show the judge and your mom that you're going to be able to take care of yourself. And this person, with the right amount of supports, kudos to his QP. His QP was amazing through this entire transition. He had a bunch of family friends too that they were getting ready to become his guardians, but we ended up not having to get a new guardian because this individual met their ISP goals, they met their budgeting goals, they met their employment goals, and this person told the clerk, that was able to stand before the judge themselves and say, hey, these are the reasons why I can be my own guardian, and I can show you I can keep my own situation afloat. his family was present, this individual who has his guardianship and now has this terminal diagnosis, was able to see this amazing gentleman flourish and not have to rely on a new guardian, because with the help of care management, they were able to work with the QP, work with the guardian ad litem, work with the DSS system to show, yeah, we don't need a guardian. We're able to, with the right supports, be in the community as independent as possible. And that just brings me to questions. So again, I just wanted to illustrate what a care management can do using some of the stories from the families in the Raleigh office.
Thank you so much, Francisco. Let's take questions from our spokes team first, but really any of you guys that have questions. Dan.
Yeah, thank you so much, Francisco. This was really, really great. In terms of, speaking with folks every 30 days and meeting them in person every 90 days, do you have any suggestions for working with folks who are maybe a little bit harder to get in contact with? Not always answering the phone, not always wanting to meet in person?
Right. So care managers have different tools at their disposal, and you do that challenge of trying to engage everybody in your list. You got to work with the tools at your disposal. Care managers have an EHR. They work with the health plans, and we're also connected to this system called NC Health Connects. When we do our assignments and we staff those care management caseloads, when a care manager tells me, hey, these are the list of people who I cannot, I can't find them, they're not picking up the phone, they're really hard to reach, we usually go into NC Health Connects and we check hospitalizations, we check recent visits. We might even go knock on the door. If we see that the person is active in their care, we verify they're currently still living at the same location. We might have sent a couple of letters. NC Health Connect is probably the best tool that we've used to find individuals who are not engaging, because especially those that are frequent flyers at the hospital, when they go to the ER room and they fill that demographic sheet, they put their current phone number in there. We can get current phone numbers from those NC Health Connects visit notes.
Great, thank you.
Marion.
So, Francisco, I have a really basic question. What is a QP? I'm still learning all the acronyms, sorry.
That's a great question. And I do try to keep acronyms to a minimum. A QP is a qualified professional. So it's going to be somebody who has like at least 2 years experience working with somebody who's living with IDD and has at least a bachelor's degree.
Thank you.
Morgan.
Hey, Francisco, thank you so much for this presentation. This is just very informative. I was wondering just if you have any strategies from yourself or from, others that you work with for how you use care management as opportunity to educate and to help build advocacy skills in families, like just some of the strategies that you might use.
Meeting people where they are. It's really about the relational aspect. I cannot say enough how relational this job really is. If you're the kind of person who likes to talk to people and do lots of visits, you're gonna love this job. It's really understanding builds trust, looking at the medical side as well. I think putting lots of emphasis on the medical aspect of care can really shine light on why has this issue been here for this long. Kind of using
Oh,
that story of that young lady who was having high behaviors. It was 100% medical.
yeah.
We came to find out that what this girl was experiencing were daily headaches. And when they did the EEG, they could see like, yeah, her head is glowing because it's in pain.
Mm.
So, it's the relational aspect, using the data, have it be evidence. When we say evidence-based practices, that could not apply more to care management. It's very data driven.
Wonderful. Thank you so much.
Gloria.
Thank you, Francisco. This has been great information. In working with Spanish-speaking families, I have to say that many complain about communicating with their care manager. Do you use interpreters? Do you have bilingual staff? Or because it is a common issue with the families that I work with.
Absolutely. It helps speaking Spanish, but I totally understand not being able to speak Spanish is definitely going to be a huge challenge. We at the Raleigh office, and really in the entire chapter of the ARC, the statewide, we use an interpreter service. Part of the care management model includes something that we call extenders. In-house, the extender, we call it a resource advocate. Resource advocate is a better descriptor of the position. So we do pride ourselves, at least in the Raleigh office, that we have many Spanish-speaking staff. So we try to hire those, and the extenders or resource advocates, you only need a a high school diploma to work that position, and you kind of work as an assistant to the care manager. And so we do hire, parents who speak Spanish, and that's been kind of the silver bullet with serving the Hispanic families, just because I totally see what you're saying, especially with the current administration policies. Building trust with Hispanic families. If you don't speak Spanish, it is a tall order. It is really hard. Meet them face to face, provide them support, have interpreters ready, because it's about showing face, really. If you don't speak Spanish with Hispanic families, it's about showing face, being as approachable and personable, not jargony at all. Like, they need to feel that you're human. The moment that you are kind of cold, hey, I'm the care manager assigned to you by Medicaid, and you're in the list of, waiver services. No, no, thank you. It needs to make sense for them at a basic ground level. You need help with the IEP? Oh, they send your son back to school, or back home from school. Let's call together and let's schedule a meeting. Working with them, holding their hand.
And the extender is something that the ARC uses, or this is all the Taylor care management?
So all the state model includes the position of an extender. How each agency staffs their caseloads, that's where the agency needs to get creative on how they're going to use that support. I know some of our offices assign a caseload to an extender. What we're trying in the Raleigh office is being more strategic and having, we have a couple of Spanish speaker extenders. We're starting to acknowledge they don't need to be assigned the same family month after month. Maybe this family needs the extender, so we assign them, we put out the fire, and then we unassign and they reassign to the next family that needs them. If the family needs help again, they just they're not thinking, whose caseload am I in? They just think, oh, let me call Laura at the Raleigh office and I'm gonna run this by her. And then once we know the situation, then we'll staff it.
Thank you.
Great question. Anna.
Thank you. Yeah, I really loved your story, Francisco, about the Salvadorian family and the way that you were able to build connections not only with the guardian, but with the neighbors and the community and the folks around. I'm wondering if you have suggestions or more detail about like how you were able to do that and how you were able to widen that support system and not just work with the family itself.
The visits, the face-to-face visits. When you work with different cultures, you start to see different modus vivendi. This Salvadorian family, you see these families live in clusters in the communities with similar families. When you visit a Hispanic family, like I'm from Mexico, we go into grandma's house, and everybody, the neighbor is coming in and out. The other neighbor is selling empanadas. They always keep their doors open, and so they're constantly saying hello to each other. They know the entire street. The more you show up, the more you're part of the day-to-day life, they'll know. Because and this particular individual, it was the neighbor who was like, hey, something weird is going on over there. Probably best that you guys go and do a wellness check, because there's just something weird going on there. We build that trust for them to be able to talk to us. I carry my cards with them. They like that. Hey, I'm speaking Spanish with your friend. They introduce themselves. Hey, here's a card. That rubbing shoulders, doing lots of face-to-face visits, getting to know the neighbors, it takes a ton of time investment. That's why I cannot highlight enough the relational aspects. It took 4 years of us visiting this family for their neighbors to get to know us. 4 years. So yeah, visit as much as you can.
Thank you.
Pam?
Yeah. Hey, Francisco, thank you for sharing all those stories. I did not realize that you guys did all those things. So this is a really basic question, but what is the process of getting referred to a care manager? Because I've talked to a lot of families that have had those issues, like waiting to be in touch, and especially, like you said, non-speaking English families. Like I had a Vietnamese family that she was told she had a care manager, and we were never able to get in touch, and then we had to go back to Trillium and say, hey, can we be assigned a care manager at Trillium, because the one that was contracted out never got in touch with them.
Right. And the way the state rolled out services was kind of clunky. There's this auto assignment algorithm with Medicaid. So hand-holding with the family who needs services is going to be your best bet. The Willy Wonka ticket to services is a psychological evaluation. So if we can guide families to find their psychologicals, if the child went through an IEP process at school, by state rules and really federal rules, they should do a psychological every 3 years. So it's talking with the family to say, when is the last time you got a psychological? That's going to be your Willy Wonka ticket to services. The next question is going to be where you live, so you figure out which Taylor plan or which health plan covers that area for Medicaid. And then it's getting them on Medicaid and using the psychological to get the care management.
All right, thank you.
Steve?
Hey, Francisco, thanks. I'm stating the obvious here, but just wanted to pay you a compliment that you mentioned like rubbing shoulders so you get to know the community. But in this role, you guys are really like rubbing shoulders with professionals. It takes someone who can really get out there and hustle to know resources so that when a family's in need, you open up your tool bag like, okay, here's the resource that you can use for this. That's so critical to build that kind of resource library for families and being able to find those and letting families know. It could be everything from working to attend an IEP or to give you advice on IEP to connecting to some particular interest that person has to guiding through very complex systems. So this whole role is complex and probably doesn't get the recognition or probably the reimbursement level that it really needs to have the level of seasoning that you have. And I know families are very lucky to have you, but thank you.
It is our pleasure, because the care management job is kind of unique in the menu of services that you can get through Medicaid, in that it's I want to say a paid family member is basically what care management is. Is a paid dad or a paid mom to I am not a doctor, I am not a clinician, I am not a nurse, but I know that if we went to the hospital last night and we came out with a discharge plan that has a follow-up visit and medications to pick up from the pharmacy, I don't need to be a doctor to make sure that happens. I just need to build the relationship, build the trust with the family, and then it's gonna happen.
Amy Eyeshide.
Hey, Francisco. I have, I guess, more of a comment than a question. I tried to think of how to word it into a question, but it's really mainly something I wanted to share that I'm a new family navigator, so I'm still figuring out what all of this means. And today I had such a great experience. I called someone, probably a coworker of yours, a tailored care manager at the ARC of North Carolina. I'll give you a little bit of background real quick on why I called her 2 weeks ago here where I work, which is at the UNC Department of Neurology. A neurology patient came in, pediatric neurology patient came in with her mom. They were Hispanic speaking. We needed to use a translator service. And the mom expressed interest in getting some support with respite services. And after they left, I called into a translator service on the phone, which was the first time for me. And I called the mom and said, tell me more about what you need from us, or what we could do to support you with this respite question. And the mom and I talked, and the mom gave me the care manager's number, the tailored care manager number at the ARC of North Carolina. And today I got in touch with her. She called me back. I feel like I have a best friend now, and I feel like she is clearly helping that family, and made me so happy to hear, because I didn't gather that from just talking to the mom. But the care manager said, she explained this long story about how some of the aggression in the daughter was happening, but it's because the mom didn't understand the right way to give the daughter the medicine for a condition that the daughter had. And the care manager was able to read the instructions and commit or convince the mom, let's try the medicine again. And the daughter's aggression went down, things got better. Anyway, it was such a lovely experience to call and talk to a tailored care manager and realize that she was happy to hear from me. She didn't take offense at why was I trying to butt into her role or her business, but she saw it as like, oh, maybe she and I both together can support the family. And it
Oh,
was just such a
that's
relief, yeah, to
awesome.
know like we're all in it together.
And they're absolutely talking to the right person, because if they're trying to get 1959 respite and they're talking to neurology, they could write a letter saying like, these are the diagnoses we're following this child or adult for, and that could be the letter that we use to qualify them for 1959 respite. So yeah, hopefully it kind of felt like relative levels of knowledge, like family member levels of knowledge in regards to, how to best support that individual.
That is a good way to put it. I felt like I was talking to someone who had family level knowledge of them. Yeah. Thank you for everything that you do too.
Yeah, and that's the special sauce, the relation.
I'll just weigh in just super quick and I'll get to you, Amy. That advocacy, that relationship, that's community organizations are really good at that piece because we've been doing it for so long. We're not the only ones. Hopefully, if you have a family member that's getting that service, whether it's from the MCO or another community organization, you're getting the same level, but we know that's not always the case. So make sure families know that they have a choice in who provides their care management services. So anyway, okay, Amy Westcott.
Thank you so much, Francisco. You guys do great work. And I just wanted to speak to what you just said, Melinda. I actually helped a family who had a care manager who was not communicative, was not reaching out, definitely was not doing home visits. And I connected them with the ARC. I actually did a warm handoff. I called the ARC, made sure that they could accommodate the family. And they helped with the changeover with Trillium. And the family was so happy just having that assistance, just reaching out to an appropriate care manager, because not all care managers are created equal, and not all care managers know IDD and pediatrics and all that the same way. So just wanted to speak to that a little bit.
And sometimes that auto assignment process might mean that somebody gets assigned to a community organization where that's not even our, it could be somebody that's substance abuse, or, it could be something that's not even in our realm. So that's awesome. Okay, Marion and Dania, really fast, and then we're going to have to move on. Marion, you were first.
Okay, so Francisco, one thing that really stuck with me was the 4 years that you mentioned that it would take to get to know kind of a neighborhood. I am Spanish speaking, brand new family partner, and so I'm going to be using my resources with Spanish. But I'm thinking 4 years is a long time. So resource wise, would you see a company like Via maybe just hiring a family partner just to get to know the Hispanic community instead of using an extendor where they're kind of going into different neighborhoods? The 4 years just really stuck with me.
Right. And that's just to highlight the relational aspect. Yes, in a jiffy, there's been families who just by the mere fact that we speak their language, bam, trust is right there. We don't need to wait like an extended amount of time. So it's really like the solution. So don't let me scare you with it takes 4 years. Many of the families that we get to know, we meet them when they're still healthy and stable. And I guess that's part of the proactiveness, the way this service was rolled out in North Carolina. We're literally meeting people where they are. Right now, they're healthy, working, and standing in their own 2 feet. But because we developed the relationship 2 years down the line when they're not, when they're knocking on the hospital's door asking for help, we already got the relational part, so it's I cannot emphasize enough, how do you hire for people who love visiting and are great conversationalists? It's not so much the amount of time you have to rub shoulders, is the willingness to breathe the air in their home.
Agreed. Thank you, Francisco.
Dania, last one for you.
Well, as someone who did case management for almost 9 years, I think you did a beautiful job, Francisco, explaining kind of the how the relationship aspect of the job really drives like how deep you can go, and how much you can really support a family if you're able to go there and really learn more about people. I think that makes a huge difference. I mean, it's really the difference between a like an okay care manager and a care manager that's life-changing. So I really appreciate you explaining that. I do have one question about how the auto assignment process works as a case manager in the other waiver. Well, in Cap C, so not being as familiar with innovations and 1915I, if you could kind of make an elementary explanation of the auto assignment and the different contractors, I guess, I'm wondering if when I work with a lot of families who are not really able to identify the name of their care manager, the organization they work with, the phone number.
Gotcha.
So I'm trying to work backwards and figure out like, okay, let's see. And I need
Do
a little
you
bit help structurally to help like what are some names that I can work with?
I want to say the out of assignment was a bigger issue at the beginning, because at the beginning you had a huge influx of potentially eligible people who are now have access to this new funding array. So now that everyone's pretty much landed where the out of assignment is gonna put them, we use NC Tracks as our software tool to tell us where is the individual currently assigned. So the individual family might reach out to our agency and say, hey, I need X, Y, and Z. Then we figure out, okay, let's look who is your care manager, who is your tailored plan. If we need to provide them care management, everything in care management is by choice. No one's forced to anything. They can just simply, they say they want to work with you at your agency. They just need to call the tailored plan that you see in NC Tracks. Francisco is enrolled with Alliance. Francisco wants to work with my agency for care management. All Francisco needs to do is call Alliance, say, hey, I'm choosing this care management agency. They're going to give me a little call reference number. And then I'm going to go to you, Dania. Hey, I called to make my switch to your agency. Here's my little call reference number. And then NC Tracks the following month should tell you. It should say that Francisco is now with your agency. So choice, member choice, by calling the health plans, they can just simply choose, I want this agency to be my agency next month. And as long as they have the eligibility established, that's that psychological. As long as that psychological is on file with the Taylor plan, they're going to be able to move around.
So as a family advocate in the community that doesn't have, that isn't doing care management, and that doesn't have access to NC Tracks, would I just go directly to their, to the LMEMC, the MCO, like in the county? And so say, this family wants to switch and have them with me.
This family wants to work with this agency and they'll switch them.
Okay.
It's called a change form.
Yep.
Okay.
If the care management agency is doing the change, if I know somebody that I support in the Raleigh office who wants to change, I file a change form. But if the family doesn't even want to deal with me anymore and they just want to switch, they can just call the main line and switch.
Okay. Thank you.
It's a pretty easy process. They'll be the two main things. Do they have eligibility? Do they have that psychological reviewed? Right. And do we know who the current health plan is? So you're calling the right health plan.
Okay. Yeah, thank you. This is somewhat similar to the other waiver, but I've never been out of the system before. So now I'm like trying to figure out who the players are. So thank you.
It's fragmented, so that's why we exist.
You guys had phenomenal questions. Francisco, I'm going to let you go unless you just want to stay for the second part, but so many thanks from all of us. You're still my favorite. Thank you. Really appreciate it. We'll get your PowerPoint.
With you guys.
We'll get your PowerPoint out to everybody.
Awesome. Pleasure meeting everybody. You guys take care.
Thanks, Francisco. Okay, Julie, I'm going to share my screen if you want to do the next part. I'm putting that up right
All
there.
right. That was awesome. I want to clone Francisco.
Oh, I know.
Pretty sure he needs to be cloned. He's awesome. So now we're going to do our family presentation review. And Miss Gloria, you're on deck. So if you will just take a moment to highlight the most important information that you filled out on your form, and Melinda will be scrolling through it for you, sorry, not with you, but for you. And once she has completed that, we will then open up first to our spokes to ask clarifying questions. So the first round is just to get clarification on something you heard, okay? And when the spokes have finished, we'll give our hub team members time. And so, Gloria, are you ready?
Yes.
Okay, thank you.
This case is about a 10-year-old boy from Nash County. He lives with his mother along with a roommate who is friends with his mother. There are two older brothers who live outside the home. The father is absent and is not involved in the child's care. Mother is Spanish speaking, but taught herself English and can understand the language. There is a history of trauma that has had a big impact in the family. There's an incident that resulted in the death of an older sister. So as a result of this tragic event, there's a lot of separation anxiety between mother and child. Family has financial issues and mother reports having difficulty paying her bills. They have transportation issues, even though they have a car, but it tends to be unreliable. This has caused many problems since the child has missed many days of school, and riding the bus has been an issue because of the significant anxiety that this represents both to the mom and to the child. Mother reports being tired, anxious, and hoping for a break, and she would like for the child to understand her feelings. The child has a diagnosis of anxiety and autism. Okay, the strengths, the individual has two older brothers that will look after him. He has a variety of interests, including cars, Legos, puzzles. He loves animals and he loves math. Mother is very caring and is doing her best to advocate for her child. About the needs of the family, they really need emotional and behavioral support. There are concerns about sudden mood changes of the child, especially at home, and the child tends to be aggressive towards mom. They have a tight financial situation and they struggle to pay the bills. They have transportation issues, and mom is usually very anxious and needs supports. Family connections, the child has an IEP, but mom reports not knowing much about the services that he is receiving at school. She has the contact information of a Spanish-speaking parent educator from ECAC. The child has a tailored plan, but they have not been able to get connected to a tailored care manager. Mother knows that the child may qualify for SSI, but still needs to apply. I gave them information about the summer camp directory from the Family Support Network, but the child does not want to separate from mom. Mom knows that the Autism Society has support groups for Spanish-speaking parents. And my questions to the team, the best way to approach the mother and son separation anxiety, any provider that could offer therapy to help with trauma and also has expertise with autism. And also my other question is helping her to connect to a tailored care manager. Apparently she does have one, but they have not been in contact.
Great.
Thank you. Okay, so we are going to open it up again. This first round is for clarifying questions. So, spokes, any of you have a clarifying question about anything that Miss Gloria presented? Dan.
Yeah, so you mentioned that the child has an IEP, but mom isn't like sure exactly what supports are in place. I'm curious if like you have seen the IEP at all or are aware of what supports are supposed to be, supporting the child in school.
I have not seen the IEP. I think even though mom understands English, there is a barrier there. But also, I think that the mom is in crisis and she has a difficult time getting connected to people. So the school, there's a social worker that knows about the situation and have shared resources with the family, but for some reason, she has not been connected to them.
Thank you. Okay, Corinne.
Hi. I know you mentioned that he was aggressive. He has aggressions towards his mother. Do you know of any aggressions towards others?
It's towards mom. And there's also, he has a lot of fear that mom might die or might leave. And this is all result of the traumatic event that happened to the family. But there are no concerns at school about the child being aggressive.
Thank you. Okay, any other spokes? All right, how about our hub team? Melinda.
Just for my own curiosity, I'd want to know, is this child speaking or non-speaking? And if you said that, I'm sorry, I did not see that in the presentation. And does he have autism with or without an intellectual disability?
He has a psychological evaluation, he has autism, and he does speak.
Thank you.
Okay, and I'm going to skip over to, we had two more spokes raise hands. So Shelley.
Hey, I did hear that you mentioned about there was some kind of contact with a Taylor Care management company. Do you know who that was, or have maybe some of the larger companies been contacted as well, like the ARC or Trillium, or I'm trying to think of somebody else, Alliance or anything
The
like
family
that?
has Trillium, and the mom knows about the services that the child qualified for. He is on the innovations waiver list, so mom has been requesting 1915I. She really wants respite services. So I'm getting the idea that maybe I will need to do a three-way call to see what's happening there, because she's waiting for the person that was assigned to her to call her back, even though she has made many attempts to contact that person, but nobody has contacted her.
Thank you.
Can I
And Jenny.
respond a little bit more?
I'm sorry, who was that?
That was me.
Oh, not, well, only for a clarifying question. So we won't do recommendations till we're finished with this section. Is that what you meant?
Well, I wanted to maybe expand on that.
We're losing
if
you.
there was a provider agency contacted as well as Taylor Care.
I'm sorry, I didn't hear the question.
Yeah, I'm sorry, you were breaking up really bad, Shelley.
I was all, with her already with Trillium, was contact made with an agency provider, the agency that possibly could provide those direct services under the management, Taylor Care management of Trillium.
My understanding is that she has been contacted at member services, and then she was assigned a Taylor Care manager, but they have not been in contact since she understands English, but maybe it's difficult for her to speak with someone.
Thank you. And Jenny, we're going to keep scooting.
Okay, thank you. I am, Gloria, you just answered my first question about the mother receiving some supports, but or services. I was just wondering, is she connected to any kind of community support groups, or even just family or friends that provide any kind of emotional or moral support?
Again, I have given her many resources, but I think that she is in crisis and she's very fearful and anxious, and that is limiting her capacity to contact people. So, like, for example, she knows about the support groups from the Autism Society, but she needs to want to be there and participate.
Okay. Thank you. And Morgan, and then we'll go to Steve. And then we're going to go to our next section after Steve.
Gloria, I was wondering, I'm trying to think about the potential therapeutic services. And so wondering, do they have access to internet or Wi-Fi? Because I know you talked about transportation being challenging.
They do have internet.
Okay.
They have a car, but it's unreliable.
Okay.
So she also knows that she has transportation through Trillium. She knows.
Great.
Okay.
One other thing, I'm so sorry. I just wanted to ask, how does he transition to school? Like, how does he, because, it sounds like the separation anxiety is a big piece and there's no aggression at school. How does he transition? Do you get a sense for that?
He transitions well, but it has been school parent work, a teamwork, because he lost many days of school because mom was not able to bring him to school. Now he's riding the bus, which took a lot.
That's
also.
That's wonderful.
But he's doing it. So it's a work in progress. And also mom is uninsured.
Okay.
Okay.
All right. Thank you.
Thank you. Mr. Steve.
Hey, is with all of the information that you've shared with the family having a traumatic event that's happened, is the family safe? Are they in danger?
They're safe, yes, but I think they need therapy. I don't think this is an event that could happen again, but it was very traumatic. They're safe.
Thank you. And I do have one clarifying question. How long ago did that traumatic event happen?
I am not very sure. I know that the child was very young, and this was an older sister. But now that he's 10, he has learned more about what really happened.
Okay, thank you. All right, so now we're going to move along to your recommendations, and following suit, we're going to start with our spokes. Who has a recommendation for Gloria? Amy, W.
Have you sat down or talked to mom and prioritized what her main needs are so that maybe addressing whatever the top tier need is would bring her out of the crisis mode?
I have, and I told her that they need to go to therapy together, but it hasn't happened. I think that's the first thing that needs to happen, and then everything will get in place. I think the first thing that needs to happen is therapy for both.
All right.
But is that her goal? Is there something in her way that is more important to her that needs to be addressed, and then she can engage in therapy?
Well, every time we talk, I have not been able to we don't go in person to the family's home. So I will talk to her on the phone. And I feel that she needs a break. She needs respite. She's trying to get that. When I have my fear is that summer is coming, and so the child is going to be at home. So I mentioned summer camps, but the child does not want to go.
Mm-hmm.
So
okay, thank you. Oh, I'm
Yes.
sorry. Okay, great. And I'm going to move over. I believe, Daniel, you were first, and then Shelley, and then Tam.
All right. Thank you for that presentation, Gloria. I have three recommendations. One is regarding connecting her with a group of parents who have children with medical and behavioral diagnoses who are Spanish speaking. I work with the executive director of the group through a mutual board that we're on, and her name is Jessica Aguilar. So I don't know if you are connected with her in any way. Are you familiar with her?
Yes, that's a great
great.
recommendation. Yes.
Okay, so if you don't have her contact information, I have her number and her email address for the Grupo Poder y Esperanza.
Yes.
Okay.
I know her.
Okay.
Yes.
And could you put that information in the chat so everyone will have it?
Yeah. So also related to Jessica, she supports a group that we're both involved in called Advocates for Medically Fragile Kids North Carolina. And our web address is fragilekidsnc.org. And I'd be happy to also add that. But
Please.
we have our website is in Spanish, and we are working on like actively having translations for as many of our services as possible. So, of course, we're all volunteers, so that's it's challenging. But Jessica has been working with us to do that. So it somewhat focuses on CAPC, but it has a lot of resources on there,
Thank you.
Yes, that would be great. Thank you.
And the final one is I actually have a little bit of personal experience with this, which if you want to talk offline, I'd be happy to. But as far as like having a sibling die, and kind of working with a child who had an older sibling die and is traumatized by that and having a lot of anxiety. I really strongly recommend EMDR, the eye movement desensitization and reprocessing therapy. It specifically works with people who have like a singular event. And so if I know people in my area who provide that, but I would strongly suggest that you look for providers who can provide that specific treatment because it can be done relatively quickly. And it could be provided to both the parent and the child, especially given that they're verbal and can engage in that way. So
thank you, Dania. If you will just please put that EMDR in the chat as well. We're going to move along. We're running out of time, and I want everybody to be able to share. So let's go up to Shelley. And if you could do this pretty quickly.
Okay, I'll do it quickly. So I'm a qualified professional, and so I have experience with this, and a lot of our clients are with Trillium. Now I understand that they're having a hard time getting with the care manager at Trillium, and maybe understanding they do have interpreting services. So maybe you can assist with that if it's making the phone call to Trillium. And maybe setting up a time where she can have interpreted services, maybe a conference call with all of you. But it sounds like she really needs to get services put in place, which of course would also include respite. I mean, I hear that need in your voice that this is something very, very important. So, in trying to find an agency provider who's actually going to be the ones to provide the services through Trillium, one-on-one most of the time, unless they state otherwise. Trillium also has on their website a list of provider agencies who are kind of contracted through Trillium that can provide these services that are needed. And if you need assistance with that, finding it, I'll be glad to help there too. But since she does have the internet, would also be good to try to search her local area in the meantime, or maybe you can help her with that, and reach out to some of these provider agencies and see if they do take Trillium. In the meantime, while you're waiting to hear for the care manager.
Thank you.
Thank you so much, Shelley. And Tam.
Yeah, so I support Nash County, but I'm not Spanish speaking. But Mariela Maldonado, she covers many of the counties in the state of North Carolina with us, and I would love to. I think that'd be a great idea to get her in touch with Mariela, and then maybe just having someone. Since she's part of the support groups and kind of talking to her and walking her, that she might be more prone to, to do it. And it's since she's part of that organization. And then Mariella can also help her with a lot of other resources and connect her with other families in that local area.
Thank you. And Corinne.
I just want to mention that the Arc of North Carolina, we do support Trillium and we support services for respite and finding staff for the mom. And she can also become, if, she did say she had some financial burdens, if she wants to become a relative as provider as well for her son, she can also do that. So I can leave my information in the chat and then you can just connect with me and we can try and help to get her services through the ARC as well.
That would be
Thank
great.
you.
Thank you so much.
Thank you. Okay, so how about our hub team? Any recommendations for Miss Gloria?
Oh, good, because it's 1:16.
Yes. I know.
Morgan, do it fast. Do it fast. I made a promise.
And I don't even know that it's going to be a recommendation because it's one more question, which was it interpersonal violence related, the trauma they experienced? Okay. All right. Because I was just going to say that that's a pathway in to get therapeutic services without insurance and might help with whatever, because there's something holding her back. And I do think like a real supportive conversation on kind of what's going on there. Could be really helpful. But I take back any other recommendations because if there was not that, then that's not going to be a support resource for them.
Okay, guys. All right. Thanks everybody for all of that. We do have to end our session today. Can I get a volunteer for next week's family presentation review?
Pam has her hand raised.
Oh, good. Thank you. Thank you so much. We'll send you that form. Next week, we're going to be talking about futures planning. Ryan Platt from A Special Needs Plan is going to be joining us. And he has a lot of great things to share with you guys. Have a wonderful week. And we will see you same time, same bat channel next week. Thanks, everybody. Bye.
Awesome. Thank you, guys.